Hello and welcome to another edition of For the Record. I'm Sean Murphy. Today my guest is Dr. Lawrence Ingman. He's from the Center for Advanced Reproductive Services at UCONN. We'll meet him when we come back, so stay with us. Welcome back to For the Record. I'm Sean Murphy. My guest today, first timer on the show, Dr. Lawrence Ingman from the Center for Advanced Reproductive Services at UCONN. First of all, welcome to the show.
Thank you very much for having me.
I know you just came from work, came from some procedures to come down here and do the show today, so we thank you for that. So you are from the Center for Advanced Reproductive Services, kind of gives us a clue of what we'll talk about today. So let's get into a little bit more detail about what exactly you do as a doctor.
So I treat patients who have infertility. I'm actually an obstetrician and gynecologist who have specialized in reproductive endocrinology. So we treat patients who have infertility and also have endocrine problems.
Right, and that means cancer, basically?
Actually, it's mainly infertility. At times, I also have a specialization in treating patients who actually have cancer and wish to preserve their fertility.
Let's talk a little bit more about you, about your background and how and why you decided to get into sort of this specialized field.
When I specialized in obstetrics and gynecology, I realized that I love babies. I love working with women, and I love helping women get pregnant. It's so exciting to see my patients get pregnant. And I really developed an interest in it, and so I specialized in reproductive endocrinology.
Yeah, there is a joy in, you know, helping someone create life, so to speak, don't you think?
It is exciting. Yeah. I really love going to work. I love meeting my patients. And it's exciting when they get pregnant.
Right.
They come back with their babies to come and visit, and I really enjoy it.
So let's get a little bit more specific. Let's talk about, you know, things like in vitro fertilization. For those that may not, you know, kind of understand exactly what it is, let's sort of give it a definition and talk about it a bit.
So in vitro fertilization, also called IVF, used to be called test tube baby,
right,
because
yeah.
You have to mix eggs and sperm in a test tube.
Right.
Basically, it's a dish. But what we do is we give women injections. It's hormone medications to try and produce several eggs. And then we retrieve the eggs from the ovaries and then fertilize the eggs with the sperm. And then keep them in an incubator. And then about 3 to 5 days later, we transfer the embryos into the uterus. So basically, that's what in vitro is.
Yeah, you know, you were talking about, you know, the old term test tube baby. It's just not really, I guess, not politically correct to call it that anymore.
Yes.
It's just not. It doesn't seem like a gentle enough phrase,
yes.
Don't you think?
Definitely.
Yeah,
it is not.
Yeah, so you need a more, I guess, a more clinical term, which is the more appropriate term for that. Now, what is there a certain percentage, you know, of society where in vitro fertilization is necessary, and why do they need it in the first place? What are some of the reasons?
There are several reasons. Initially, the commonest reason is tubal factor. So if you consider natural conception, you need a sperm, you need an open fallopian tube, you need an ovary, and you need a uterus. So what happens is when the egg is released, it's picked up by the fallopian tube. And then the sperm enters the egg and fertilizes the egg. And then the fertilized egg goes into the uterus and implants and becomes a baby. Now, if there's a problem with any of these steps, then there may be difficulties with conception. So typically, if the fallopian tubes are blocked and not open, then in vitro fertilization may be an indication. If there's a problem with the sperm, for example, if there's a problem with the number of sperms or the proportion of sperms moving forward, then it will be difficult for the sperm to get into the egg and fertilize it. If the woman does not release eggs, then that may be a reason. Or if there's a problem with the uterus, then it may be difficult for the woman to get pregnant. Now, old age, especially in women over 40 years of age, it's more difficult to get pregnant, and that's one of the commonest reasons why and patients may require in vitro fertilization.
Now, they're probably getting close to going through menopause at that point, right?
Yes, usually menopause occurs around the age of 50.
Okay, so a little bit,
But
little time. Then.
yes, but usually after 45 years of age, it's extremely difficult to get pregnant. And pregnancy rate around 45 years is about 1 to 2%. And usually the pregnancy rates tend to go down after the age of 35.
You know, and the cruel joke that they, you know, people say is men can, you know, they can have babies at any age really, and women, and it's really true what they say about the biological clock, isn't it?
That is very true. Unlike men, where men tend to produce sperm all the time, women are born with a finite number of eggs. And as time goes on, they lose the number of eggs that's within the ovary. And after the age of 35, the number of eggs within the ovary diminishes. And therefore, it makes it more difficult to conceive.
Now, don't some women decide to remove some of their, or kind of preserve some of their eggs so that, you know, for future use, or maybe during a time when maybe medical concerns aren't as large? Talk about that a little bit.
It's becoming more popular for people to do that, especially people who are professionals and haven't met the right guy. It is reasonable to undergo IVF and then remove the eggs and then freeze the eggs for future use. So, for example, if you are 30 years of age and you remove your eggs and freeze them, and you come back around 40 years to use them, your pregnancy rate will be the same as somebody who is 30 years of age.
Right. And the technology, is it advancing all the time in that area to kind of improve your chances?
The technology has improved significantly. Yeah. The first frozen egg baby was in the 80s. However, it's taken a long time for us to get to where we are. Initially, the pregnancy rate was around 4 to 5%. Now, pregnancy rate is up to about 50%, 45 to 50%, if you freeze your eggs, depending on your age.
What's the reason for the you know, the advancements in the research and development? What has caused that to happen?
One of the major problems with freezing eggs is that there is formation of ice crystals within the eggs. And therefore, you need a right technique to use to be able to successfully freeze the eggs and thaw them. And over the years, there's been improvements in the technology for freezing the eggs and thawing them. And therefore, the pregnancy rate has improved significantly.
That's why they don't really have a handle yet, I guess, on what they call cryogenics or something like that. They're really, you know, I don't know how far along they are in that field, but I mean, one of the problems with that technology is, you know, what happens to the body after you freeze it, and thawing it out, I guess, without there being damage, which I don't know if that's the case now.
That's very true, because if you freeze the eggs and you don't freeze them properly, and you thaw them, there may be damage to the egg, there may be damage to the chromosomes within the eggs, and initially there was an increased risk of chromosomal abnormalities and birth defects with egg freezing. But with changes in the media and the way the eggs are frozen, this has reduced that problem.
When people talk about, you know, because they can't get pregnant, talking about taking fertility drugs, what are they talking about when they say that?
There are several different types of fertility medications. The commonest is called Clomid, which is a tablet that you usually take for 5 days. And then there are injectables, which is called follicle stimulating hormone. It's actually a hormone which is similar to the hormone which is released from the brain, which stimulates the ovaries to produce eggs.
Now, when someone takes fertility medication, I've noticed that if they do conceive and get pregnant, usually because of the amount that's going, you sort of have to overcompensate, and so they'll likely end up having twins sometimes, or in situations like that, and that's like, it's par for the course, isn't it, in that case?
Which is a major problem with fertility medications. Our aim is to help the patients get pregnant, but it is also our aim to reduce the probability of multiple gestation. One of the major problems with in vitro is that we still do not have the technology to select the single burst embryo that will become a baby. If we can do that, we will transfer one embryo for everybody. However, because we don't have the technology, we'll have to transfer more embryos in order to improve the chances of conception. And henceforth, you also have an increased risk of multiple gestation. We have, however, made significant strides over the years, And now we're transferring fewer and fewer embryos.
Which means the less likelihood of twins or triplets or something like that. You know, when people say they want to start a family, I'm not sure if they necessarily want to start off with a large family like that right off the bat. Right?
Exactly, because there are significant problems with multiple pregnancy. There are significant financial problems,
Right, yeah.
psychological problems, and also if the babies are born early, especially around 23, 24 weeks, the babies have significant problems,
Yeah.
such as cerebral palsy, handicaps, breathing problems, eating problems, and as well as increased risk of cesarean sections and also complications during the pregnancy. And therefore, it's very important to try and reduce that risk.
Now, can you tell ahead of time before, you know, shortly thereafter conception, if the children inside are going to have those types of problems, some kind of disease or something along those lines?
I think most of the problems associated with multiple pregnancy is related to preterm delivery.
Okay.
So if the babies are born early, around 24 weeks, then they have a tendency to have significant problems.
But like you said, as time goes on, you know, the risk factors are being reduced because, you know, the technology is advancing a little bit. Granted, there were still, you mentioned some areas where we're still not there yet. Do things like, you know, understanding the, you know, mapping the genome a little bit, I mean, does that help at all in these sorts of situations?
It does in a way. I mean, now we have technologies such as pre-implantation genetic diagnosis, where you can actually take a cell from an embryo and then test the chromosomal makeup of the embryo. For example, if you have a disease such as cystic fibrosis is a genetic disease which leads to chronic lung disease, and the children tend to die at a young age. Now, if the couple are carriers of cystic fibrosis, now we have the technology to be able to actually take a cell out of an embryo, test the embryo, and only replace embryos without the gene. So there has been improvements.
Well, yeah, and so you can definitely see a light at the end of the tunnel, so to speak.
Yes, definitely.
Let's take a break. We'll get back to more stuff. Dr. Lawrence Igman is from the Center for Advanced Reproductive Services at UCONN. So we will take a break and come back. I'm Sean Murphy. This is For the Record. Stay with us. Welcome back to For the Record. I'm Sean Murphy. My guest today is Dr. Lawrence Igman from the Center for Advanced Reproductive Services at UCONN. It's a fancy name. In reality, you are a gynecologist and an obstetrician, you said, right?
Obstetrician, gynecologist.
Right. Flipped them around. And your specialty, the fertility stuff that we talked about. And I want to get into, I guess this is a tougher subject because it involves cancer. And that's oncofertility. Is that how you pronounce it?
Yep.
Talk about that. What is it?
Oncofertility is a procedure where we offer fertility preservation for patients who have been diagnosed with cancer. Now, this has become more popular lately, and this is because cancer survival has improved significantly since the 70s. And this is because of improvements in diagnosis and also improvements in treatment. Patients are living longer, and therefore quality of life issues is more important. And one of the most important quality of life issues is fertility. We know that cancer treatment may lead to detrimental effects on reproductive function.
Because sometimes it hurts the good stuff as well as the bad
Definitely.
stuff. Right.
So you're giving cancer treatment for the cancer, but it may also affect the ovaries and the sperm, such that patients may lose the eggs within their ovaries and therefore may not be able to get pregnant. And therefore it's important to be able to offer these patients options before they undergo cancer treatment.
And how long have you been doing this for, by the way?
I've been doing this particular field about 4 years or so. We opened our Oncofertility Center program about 4 years ago, and we've had a lot of referrals from oncologists in the area.
So basically, what are the effects of cancer therapy on female fertility? Like you said, it could damage the ovaries, but maybe get a little bit more specific about it.
So the way I look at it is women are born with a specific number of eggs. And as time goes on, they lose the eggs within the ovary. Now, cancer treatment in the form of chemotherapy or radiation may actually destroy the eggs within the ovary. And therefore, if you destroy the eggs within the ovary, this may lead to infertility. It may lead to premature menopause, and therefore patients undergo menopause earlier. They may have hot flashes, night sweats, and mood swings, and may have difficulties with getting pregnant.
So the idea is to remove the eggs before cancer treatment begins. Basically after diagnosis of cancer, but then before treatment begins, so that you can remove the eggs or some of the eggs or however you do it, and you preserve them so that they can either, in vitro fertilization or, if there's, great progress on the patient's part as far as the cancer treatment goes.
Exactly. It is important to counsel the patients before their cancer treatment, to offer them the options before their treatment, to let them know that cancer treatment itself may affect their fertility. And the options include, like you rightly mentioned, in vitro fertilization. And you can freeze the eggs, you can freeze embryos. So fertilize the eggs with sperm and then freeze the embryos. You can also actually freeze ovarian tissue itself. So you can take the ovary out and then freeze the ovary before cancer treatment.
Now, maybe just having cancer in and of itself may not be enough. That's sort of a general term. Is there someone who's considered an ideal candidate for for the fertility preservation that you were talking about?
Yes, mainly young patients, young women who have been diagnosed with cancer. Usually women under 38 years of age who have been diagnosed with either breast cancer or leukemia or lymphoma and are about to go through cancer treatment that may affect their fertility.
Mm. And for them, and this is again, an area of speciality for you, are there certain things that you would recommend depending on the patient and what's going on with them versus another, another option?
That is very important. It's important to consider how old the patient is. Is the patient married or is she single? And what time is available for her to undergo the treatment? So if you have a young woman who is single, it is important to consider freezing the eggs rather than embryos. And if you have a patient who is going to undergo treatment within 48 to 72 hours, you don't have enough time for that patient to undergo IVF, and therefore they may opt to freeze their ovaries.
Yeah, I was going to ask you, if time is of the essence in this sort of thing, depending on whether treatment is necessary immediately, because there are certain situations I would imagine where you cannot hold off on your cancer treatments in order to do this, right? I mean, you may need it right away.
Definitely. And we stay in close consultation with the oncologist. And in the past, if you were going to do in vitro, actually the treatment lasts about 10 days or so from the time,
cancer treatment, or
no, the fertility treatment.
Okay.
So from the time you start injections to the time we take the eggs out is about 10 to 14 days. However, depending on when you're seeing, the scheduling itself for the treatment may take about 2 to 6 weeks. However, we have developed protocols now so that we can start a treatment anytime when the patients are referred to us. So at most, we will delay the treatment usually 2 weeks or so. And there has been several studies that have been done that have shown that this is not detrimental to their cancer treatment.
And you had mentioned this before, counseling is really necessary, because you can, you get into a situation where once, maybe depending on the person, once they find out they have cancer, their whole, idea of maybe starting a family changes. Maybe, it diminishes their desire to even want to start a family, and so they really have to, consult with their significant other, but also doctors like you so they can understand that, regardless of what that bad aspect of their life, this is still possible.
Exactly. And this is one of the most stressful times in their life. They have been told that they have cancer, which is a significant diagnosis.
Right.
And now they're being told that this may affect their fertility, and they have to make decisions as to what to do. I think where I come in is to counsel them and say, look, this is what cancer treatment can do to your fertility, and these are the options available for you. Now, you may choose to preserve your fertility, or you may choose to proceed with the cancer treatment. And then after the cancer treatment, there are still options for you, such as adoption. Actually using donor eggs is an option. But it's important for the patient to be counseled, right, so she has enough information to decide what to do.
Typically, what does a patient in that situation usually decide to do? Does cancer take over their life psychologically as well, where that's the thing that they concentrate on and maybe forego the family, at least for the fertility part of it, because their goal is to be a survivor at this point?
I think it's about 50-50. 50% of patients may opt to proceed with the cancer treatment without preserving their fertility, and 50% of women may decide to undergo some form of fertility preservation.
Well, in that case, it kind of lets you know that they're a fighter, that they are going to be, and they're
definitely.
They're going to be a survivor, and they're going to beat it, and they're going to still want to start their family after.
Definitely.
Definitely. What a challenge, and what a strong-willed person that has to be able to, like you said, carry that burden. And that's why the counseling and what you do is so important, because I would imagine, and this is probably true, that if somebody if somebody knows they have cancer and there's a possibility that they, this could take their life, they may not necessarily want to have a child that would be without a mother, right?
Definitely. Those are some of the things that women take into consideration. However, because they know that the technology has improved and they are more likely to survive, most patients may opt to freeze or preserve their fertility.
Especially now, as we talked about, technology advances all the time,
Right.
and it gets better and more precise, I would imagine. I want to talk about you a little bit more before we wrap up the show. Maybe some of your day-to-day duties, and maybe not every day is the same for you, different things. So talk about what you do on a typical day.
Exactly, and that's exciting for me because I have a variety of things I do. I see patients. A typical day may include me seeing patients in the morning and afternoon, and that will involve new patients who have been referred for fertility and also certain endocrine problems. And then there are days that I do surgery all day, minimally invasive surgery, which involves laparoscopic surgery. And also there are days that I'll be doing procedures, doing the IVF procedures, retrieving the eggs and fertilizing them. I also enjoy doing research because I think to be able to manage a patient better, you have to have a clear understanding of what the field suggests and what the literature suggests. And asking the questions and answering them through research is very important to me. So it's part of my daily activities to think about the questions and ask how we're going to solve those questions by doing research.
And that's how you advance, is research and development and technology, and that's what it's all about, really. So, and for you, like you said, no day is the same for you. And that's what keeps it exciting. It's not mundane, and it's a fascinating field. And your description of it gives people hope. With all that we've talked about today, the in vitro fertilization, and even the sort of the tougher stuff like the oncofertility. If somebody's watching the show today and they may be concerned, or I hate to use the word misconception, but maybe you could alleviate some of their concerns or fears.
I think what people should know that a lot of women go through fertility problems, but that's why we're there. I usually tell my patients, leave all your problems to me, and I'll take care of it. Just enjoy the ride.
That's right.
But I think one thing you should know is that you're not alone, and we are there to support you. And if you've been diagnosed with cancer, also you know that there are options for you. And there are several resources, especially patients who have been diagnosed with cancer. There are several resources for them online, for them to have information about what the options are.
And you know what? There are lots and lots of survivors of cancer, too.
Definitely.
Dr. Lawrence Ingman, thanks so much for being on the show. He is part of the Center for Advanced Reproductive Services at UCONN. It was indeed a pleasure having you on. Hope you'll come back, okay?
Thank you very much for having me.
And thank you for joining us for another edition of For the Record. I'm Sean Murphy. We will see you next time. Take care.